name's Dianne Sinnige. I'm a physiotherapist, and I am the policy lead for the Canadian Alliance of Physiotherapy Regulators. Ivy recently asked myself and Sarah and a few others to speak at a policy conference. She just asked us to speak again to provide some background to the rest of you at this update meeting. So what she asked us was, at that time, was what was the impetus for working on the MDS, and what was our experience from the physiotherapy profession. So what I'll start with is just why we were attracted to the project. The project started a number of years ago, and Ivy approached us to ask if the physiotherapy profession was interested in participating and supporting, writing a letter of support for this research project. And so there were some discussions with the registrars across the country at that time. And what we heard was that the registrars, in principle, support health workforce planning, and they understand that they play an important role in providing data that assists in health workforce planning. So they were in support of participating in this project from a principled perspective. Another thing that was important to them was that if they had a data standard that helped with the standardized collection of data, it might make their data submissions easier if this standard is adopted by CIHI. So some of them do make submissions to CIHI already, and sometimes the data submissions were a bit more onerous than they wished it was, and they had to do a lot of data cleaning, and there was not, they didn't all collect their data exactly the same way. And so if there was a data standard, that would assist. Thirdly, and this has come more and more to light since we've joined the project, there of course has been a movement toward greater diversity, equity, and inclusion discussions, and the physiotherapy regulators understood that they can't track this unless they collect data on it. However, probably a lot of you have determined that it's you need to be sensitive when you're asking questions about demographics. And so they appreciated the idea of having a discussion and getting some guidance on how to sensitively collect diversity information. So those were some of the reasons that they were interested in this project from the position of the profession. A second thing that was going on, and this may be unique to our own profession, but at the time, the regulators across the country were noticing we're looking for trends in professionalism issues. They wanted to participate, or they wanted to take an approach of risk-based regulation that I'm sure you've all heard about. And the way to do that requires data on where the risk is, where are physiotherapists having their issues with regulatory issues. And so they tried to compare their data across the country on professionalism issues, and they found that they were collecting their data in a myriad of different ways, and they couldn't actually compare their data. So they could not make plans or identify the greatest risk areas regarding professionalism issues because they couldn't compare their data. And so when Ivy approached us to participate in this project, I described this issue that we were having, and she made the observation that this is the kind of thing that they do, is that they help people collect data in a standardized way. And this is where we came up with the idea of maybe having an extra module that was all about the collection of data relating to professionalism and disciplinary issues. And as that idea got worked up, it now looks like there may be a module that you can compare data, not only for physiotherapists, comparing data in a standardized way across the country, but it will be for all across professions. So there will be some standardization, not only across physiotherapy, but across professions. So we're very interested in improving the quality of our data collection in that particular area. And then just a third note that I would make, and this comes from me personally as a former caregiver, as a direct patient caregiver. I had in our discussions mentioned that what I found frustrating about providing workforce data, I'm all for providing workforce data, and I do that every time I renew my license with my regulator. I also did it with my employer at the end of every day. I had to track my, the time I used providing care, providing non-patient care, professional development, all that kind of stuff. But nobody collected the amount of time that my colleagues and I were spending providing unpaid overtime care. So when there were shortages in staff, we simply were asked to take on the caseload of other of our coworkers, and that meant that we had to just stay late, work late. We didn't get paid for this. There was no tracking of these hours. And I made the suggestion that if you really want to understand the risk of burnout and where the capacity pressures are, you don't want to just ask how many hours did you work. You want to ask how many regularly scheduled and paid hours did you work, how many overtime paid hours did you work, and how many overtime unpaid hours did you work, because these things vary across professions, whether you get paid or not, whether they're scheduled or not, whether, we never got paid for overtime hours in my time. I don't know, maybe that's changed. So that was another suggestion, and I can see that feedback has been incorporated. So it'll be interesting to see if there's any way of doing that. I realize it will be a big challenge. So, but I feel like I've been heard. So that's a bonus for me. And that's about it for me. Unless is there anything else, Ivy, that you wanted me to discuss?
No, I think that's great. Thank you so much, Diana. I really appreciate it. And I think what we'll do is we'll pass over to Sarah, who will present her perspective, and then just encourage all of the participants to post their question in the chat. We can address those before we break out into the breakout rooms. And just to let everybody know, in the breakout rooms, all of the members of the team, there will be members of the team in each of those rooms, and they will be able to show you all of the different data elements so that you can kind of walk through and say, what are some of the considerations for these specific data elements? What's missing? And exactly as how Diana has suggested, we didn't have anything specifically on paid and unpaid overtime, that being really important, especially for sustainability of the workforce. So really appreciate that input. And I think that really resonated with the other case studies. And so they were very positive about that. So we did incorporate that. So thank you for that. So I'm now going to have Sarah present in regards to the case study that she is leading at the Ontario Medical Association. So over to you, Sarah.
Thanks so much, Ivy. I am a family practice anesthetist and a health workforce researcher. I'm the co-lead of the OMA OHRC, which is the Physician Resources Committee, and I also lead the Data Supports Working Group at the OMA. The Ontario Medical Association is a professional association representing 43,000 physicians in Ontario, and we became involved in this project because of internal recognition of the importance of data, the need for data to support organizational policy activities, advocacy, decision-making, and also to support our members in an equitable way. And so over a year ago, maybe 18 months ago, this data supports working group was constituted, and we've been gradually kind of working our way through how do we advise the organization about the best way to support workforce decision making from a data-driven point of view. And when the opportunity arose to become a demonstration project partner, we jumped at it because we felt that it would really help us to look across other minimum data standards to align data that our organization uses with those from other professions so that we can get closer to being able to characterize team-based care, which is really how care is being delivered more and more these days. And without standardized data, it's really hard to figure out who's doing what, for whom, with whom. And so we saw a lot of opportunity around being part of this project. What we have done is, well, and we're actually still in the middle of our work. It's a stepwise process. So the first thing we did was assemble and we did an inventory of OMA data assets. And then we went through an exercise where we compared OMA data assets to the MDS, um, with a view to identifying whether or not each data element met the standard, exceeded the standard, or fell short of the standard. And that gave us a little bit of a way to assess the data that the OMA has, but also a way to identify gaps in data that could be remedied. And a minimum data standard is an excellent way to do that, since if you identify a gap, not only do you know that you're missing a data element, but you also know what that data element should look like and how to collect it. And so that's tremendously useful for our organization. Um, in addition to doing that exercise, we are also, so having gone through the list of um, OMA data assets, compared them to the MDS, and developed a kind of meta list of data and tools that could be used to address workforce questions. We're now in the process of applying that list to a set of policy and planning questions that we came up with at the very beginning of the work of the working group. And the idea behind that is to say, to determine whether there are any policy and planning questions that we are interested in addressing that are not covered by the data and tools that we either have or aspire to have. And so we're in the middle of that work right now. And what we expect to be able to provide back to the MDS team is feedback from a couple of different angles. So we expect to be able to comment on the data elements themselves. And we talked a lot about each element, really, and about whether it applies to medicine in general, and then whether it's useful for the Ontario Medical Association in particular. And so there's sort of two streams of feedback that I expect to be able to provide, recognizing that our perspective is that of a medical association, not a medical regulator. And we would hope that some feedback from the medical regulators could also be incorporated into this process, because we come at things from a slightly different perspective, and from a slightly different, with a slightly different function. So we will be providing feedback with respect to whether the data elements in the MDS apply to medicine in general. And some of that is easy. So, for example, bridge training isn't really a big thing in medicine. And so that, we're going to be able to say, yeah, this is an important element, but for medicine, it's less important. Some of that is. Um, is clear in terms of this is an important element for medicine, but not for the OMA because we have a different data element that covers this, or we've been looking at this in a different way. And so those two streams of feedback we expect to be able to provide, as well as um, hopefully the overall recommendations that come out of the work of our data supports working group, with respect to how the organization is going to tackle gaps in data um, and in process. And as an example of that, although our recommendations aren't fully solidified yet, I know for sure that we are going to have a set of recommendations that relate to equity, diversity, and inclusion, and that we're going to recommend not only specific things about the data elements, but we're going to recommend to the organization that a process be set up to guide the collection, the stewardship, and use of these data elements in a way that makes sense and that is sensitive and equitable. Um, and so, though that's kind of a little bit about the background of how we became involved, a bit about what we're actually doing step by step and where we're at, and then a bit about what kind of feedback we anticipate being able to provide. And we want to, yeah, we expect to be in a position to provide those 3 streams of feedback very shortly. I'll stop there.
Thank you so much, Sarah. That was really, really helpful to get the experience. And a couple of things that I want to emphasize from the feedback that Diana has provided and that you have provided, that the health workforce minimum data standard, as we are designing it, is not all or none. It's not like you have to collect all of these data as an association or as a regulatory authority, or we could have educational partners or employer partners. And so it is very much not an all or none. So for example, there may be some elements in the enhanced that make sense for your particular profession. There may be some other data elements that are not in the data standard that are still important to develop. So I'd like to actually pose to both Diana and Sarah, if you could speak to those issues, and Diana, especially from a regulatory authority perspective, what have been, what has been some of the feedback that your members have stated in terms of what's appropriate or may not be appropriate for a regulatory authority, what might be more appropriate for a professional association? So maybe if I could have you speak to that, Diana, and then Sarah, you can come back to those issues.
Well, I'd really love to help you and answer that question, but I need to make the distinction that I'm not actually a regulator, that I support there are 11 physiotherapy regulators in the country, and I support them on centralized projects. So all I can really speak to is what it's been like to just try and get everybody together and make them aware of your project. We did work on a memorandum of understanding so that we understood each other, what was expected of each other. We did need a bit of clarification in that process about what was the relationship between this minimum data standard and the minimum data set. And what Kai-Hi was doing, we were a little bit confused about, does this obligate us to provide data to anybody? And you clarified that this is really just about advising on standardizing data collection, but we would not be submitting any data. So that's not part of this project. So that was what we clarified. I hate to put my regulator colleagues on the spot, but I will say that we have, out of the 11 regulators, I'm not sure, is it 4 or 5 have signed the MOU to 5 have signed the MOU to work with Canada Health Workforce Network on this project and review the minimum data standard and provide advice. And I think at least 2 of them are here, Craig Roxborough and Jennifer Billick. Please don't hate me for throwing under the bus here. Are you able to provide any perspective on what it's like from the regulator's perspective?
I thought you might throw it to us, Diana. I mean, we're still early days. So sorry, I'm Craig Roxborough, I'm the Registrar and CEO at the College of Physiotherapists of Ontario. We're still early days in terms of how we're analyzing it and going through a similar project to what Sarah described, where you're looking at what we currently collect, analyzing it, mapping it, understanding what the change would be and what the implementation would look like. But Ivy, your last comments were really interesting around sort of a coordination across the sector so that the different players can collect the right pieces in the right places rather than the regulator collecting all of it. And so, Sarah, hearing you talk about the OMA's work in this space is giving me some pause and some reflection as to whether we're the right folks to collect everything or whether we can work with some of our partners to collect some of this information, which may absolve some of the challenges that we have when we inundate our members with many, 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 many questions, some of which are sensitive and personal. So some interesting reflections are coming for me as a result of that.
Thank you, Craig. That was really helpful to get your perspective. Sarah, would you like to respond to the questions?
Sure, thanks, Ivy. In terms of our experience being a part of this project, I would say we just feel enormously fortunate to be undertaking this work at exactly the right time. Being able to work with the MDS has given us reassurance about what is considered to be the standard, not just this standard, but because of the rigorous methodology used in this project, we can look all the way across and we can see what's being done at CIHI, although that doesn't apply to medicine, what's being done in the US, what's being done at the WHO, what's being done elsewhere. And that is super helpful in terms of being able to then turn around and say to the board, here are our recommendations about what standardized data with a workforce dimension should look like. So that's one thing. The comprehensiveness of the standard and the process has also been really great and just, again, gives me a lot of confidence when I eventually look ahead to going and standing before our board and saying, this is what we recommend you do. In terms of the sort of split between who collects what, you know, we're having lots of conversations on the other side, the non-regulatory side, and I think we see there's in medicine anyway, there's a huge interest in physician mental health and in equity-related issues, and we see both an opportunity and a responsibility as a medical association to step into that space and start collecting data that physicians may not be comfortable sharing with the regulator. And again, making sure that the safeguards around privacy and security, around collection and use of that information are in place. We think there's a real potential to do good by putting into place a process that allows a more comprehensive data set about physicians, especially in these areas, that is separate from the regulator. And, you know, we envision a future where we can work together with the regulatory authority to answer questions that are of mutual interest in an anonymized, de-identified way. We have data, they have data, we can link those data and answer a question. And that's what we've spent quite a bit of time talking about, not just kind of what is possible right now or the roadblocks right now, there are lots of those, but what kind of environment we could work in the future.
Absolutely. Thank you so much, Sarah. And what was really profoundly insightful for me when you presented at the previous panel that Diana mentioned is that there presently is no data standard for medicine in Canada. And I was just like, you're right. I totally forgot because there are other minimum data standards. The CIHI minimum standard, as you mentioned, the Health Professions Database standard in Ontario, and neither of those apply to medicine. So, particularly important. And you also noted the importance of ensuring that we were working with an international environment, which was in part why I wanted to start with that, is that there are international reporting requirements that we have to different compacts, to the International Labor Organization, to the WHO. And Margaret Walton Roberts and I have done some work looking at the reporting and have come away with the importance of a standard approach internationally. And we have some international colleagues joining us today. So I'm happy to recognize you and also just to kind of let us know why you were interested in this work being done in Canada. And because we are trying to make this be mindful of an international reporting context. So thank you for those comments and feedback, both Diana and Sarah.